Good evening. I'm Nadim Kafarani, European Clinical and Business Manager for Ultrasound. I'm very pleased to welcome you to this liver ultrasound webinar organized by Canon Medical Systems. Let me start with one important point regarding questions and answers. Please use Q&A function of Zoom platform for asking questions. They will be discussed at the end of the two lectures. This webinar will introduce some advanced ultrasound techniques used in the assessment of diffuse liver disease. For that, I feel really honored to introduce our speakers for today, Professor Valérie Villegrain from France and Dr. Giovanna Ferraioli from Italy. Our first speaker, Professor Valérie Villegrain, is Professor of Radiology at Beaujon Hospital in Clichy, Educational Director of European School of Radiology. She has extensively published reviewed research for numerous international journals, including European Radiology, Liver Transplantation, Hepatology, Journal of Hepatology, and is currently Associate Editor of Radiology. And today, she will present her experience about multi-parametric tools for liver disease assessment. Professor Villegrain, I give you the microphone. Thank you.
Good evening to all of you, and maybe good morning for those who are not in Europe. I'm very pleased to lecture about the multi-parametric tools for liver disease assessment. And then I would like to start, by saying that ultrasound is, by essence, I would say, a multi-parametric tool. For those who work with ultrasound, it is fascinating to see all the improvements that have been put in the machine. Let's start with the B mode. Then we had the Doppler, the color Doppler, then the duplex Doppler, and then the microflow. But today we will see other quantitative approaches that are very helpful in liver disease. Why is it important to non-invasively assess and quantify liver disease? Because chronic liver disease are growing. It is a major burden in all countries, all continents, and it is very important to diagnose, stage, and to monitor this patient. And for that, ultrasound is really a great tool. So which chronic liver disease are we talking about? Two things. First of all, a very classical one, to stage and diagnose fibrosis and cirrhosis. As you know, cirrhosis is mostly related to chronic hepatitis infections or alcohol misuse. Having cirrhosis, it is also important to appreciate the severity of portal hypertension. For these two important points, liver biopsy first and direct measurement of the hepatic venous pressure gradient are really the reference tools, but they are invasive. Can we replace them, and can we non-invasively stage fibrosis and evaluate the severity of portal hypertension? The answer is yes, by looking at liver stiffness. The second big chapter of liver disease are non-alcoholic fatty liver disease, which is really a pandemic, not exactly like COVID, but a very important medical healthcare issue. And for that, again, liver biopsy is the reference method assessing not only fibrosis, as we have seen with the classical cirrhosis. Again, we can do that by measuring liver stiffness, but also by assessing the presence and the quantification of fat within the liver by measuring steatosis with different techniques. And last, but probably even more challenging, this is to analyze the activity within the liver. And for that, we have new tools such as the dispersion slope that can reflect the viscosity of tissue. Here, the question is really important. It is to assess whether the patients have simple steatosis versus non-alcoholic steatohepatitis that may lead to several complications, including cirrhosis. Let me start first by, now I would say, a routine tool for radiologists, ultrasound people, that is liver stiffness. The very first technique that used liver stiffness has been the transient elastography that was able and is still able to diagnose the presence of fibrosis, to assess the severity of the fibrosis, and eventually to diagnose cirrhosis with a degree of portal hypertension. Now we have several ultrasound-based techniques, including the Aplio developed by Canon, that allows not only to assess the liver stiffness in one point, but to give you a 2D map. And we can see here 4 different patients with increasing liver stiffness, from the normal one in dark blue to a patient with a cirrhosis with a mixed color and mostly red. Indeed, as a new technique, we have to fulfill the requirements. So I don't want to emphasize too much this. This is very well explained in the guidelines, but I just want to stress that it is very important to have adherence to a strict protocol, because the diagnostic value of shear wave elastography is based on patient status and also the technical part of the exam. Now, we know that there are several ultrasound-based techniques that has been developed by several companies, several manufacturers. But we know also that shear wave elastography may vary according to the machine, according to the beamformer, according to the ultrasound probe. So every time we have to validate a new technique developed by another company with either the liver biopsy or the reference method, which is the transient elastography. So we can say now that with the Aplio series, the shear wave elastography has been clearly validated in a multi-center study where Dr. Giovanni Ferraiola participated, as well as our centers, as well as others. We have included more than 500 patients comparing the liver stiffness measurements by the 2D shear wave technique from Canon and the transient elastography. First of all, the ultrasound-based technique are very reliable and with a high applicability, which is indeed important. Second, we have shown, and this is the graph on the right, that the liver stiffness measurement using 2D shear wave elastography with the Aplio suits correlates extremely well with that obtained with the transient elastography. As you can see here, it tended to underestimate higher stages of liver fibrosis, but actually who cares if the patient has 30 or 32 kilopascal, because he definitely has cirrhosis. But very interestingly, it correctly classifies the majority of the patients. If we look at also more details and the several grades that we use usually, we were also able to demonstrate that the liver stiffness by 2D shear wave elastography was very well correlated with the different categories of liver stiffness according to different thresholds, the stochastic one or the Baveno-6 one. And we have been also looking at the number of measurements to get a reliable measure, and we observed that 3 measurements were enough to get a high reliability. So with that, I think we have now sufficient evidence to say that 2D shear wave elastography using the Aplio Canon is extremely reliable and has a high diagnostic performance for liver stiffness assessment. The second question, as we have seen, is can we quantify fat on ultrasound? Well, we know for many years that fat quantification is important. We have done that semi-quantitatively for years. We can use several ratios, the hepatorenal ratio, but the reliability was not that great. And thanks again to the CAP technique that showed that by looking at the attenuation measurements, we were able to observe the nice correlations with the intrahepatic fat content. In other words, higher the attenuation of the ultrasound wave, higher the intrahepatic fat content. And this is an example that we may obtain. In the bottom right, you see here two different in phantom studies tissues with different grades of fat within the tissue. And you can see that with the attenuation measurement, we can depict clearly the presence of fat. But I don't want to highlight and focus so much on fat quantification because Dr. Farrell Yuli will speak about that. Now, the third question, which is still more difficult than the first two, is can we evaluate liver inflammation, which is extremely important, and especially in people having NAFL disease. We can have a nice display using the Apleo series with on the top left, the liver stiffness. We can have an idea of the propagation map, and this helps to place the ROI within the map. There is the B mode, and here, in the bottom right, you see again the map of the dispersion slope with again two different tissues with a different viscosity. So we can guess that we can capture the viscosity of the tissue. So how we do that? We look at the acoustic dispersion. And what is acoustic dispersion? It is a phenomenon of a sound wave separating into its component frequencies as it passes through a material. So the separation of the frequencies is measured by the rate of change in phase velocities. And this is the technique that has been used to estimate the dispersion slope of the speed versus frequency in order to evaluate changes in tissue viscosity. So the dispersion slope value is correlated with viscosity, and we think that viscosity could be a proxy for liver inflammation. Again, higher the dispersion, higher the viscosity. Interesting graph that has been published by Dr. Sugimoto and colleagues showing that indeed there are relationship between the shear wave speed and the shear wave frequency. In a perfectly elastic tissue, shear wave speed in constants regardless of shear wave frequency. And however, in other tissues, which are the human tissues, viscoelastic tissue, the shear wave speed does vary depending on shear wave frequency. Look at the graph, and if the shear wave elasticity is fixed at 2 kilopascal and shear wave viscosity varies, then the slope becomes higher according to the shear velocity level. And this is exactly what we want to capture. So having obtained this quad view in two different patients, you see that the maps are clearly different. Not only the shear wave elastography map, but also the dispersion slope map with the change in colors in the bottom images. And looking at the biopsy, these two patients are different. The first patient has a healthy liver, whereas the other one has a fibrosis level 3 and some degree of inflammation. However, looking at the literature, we can see that there are discordant results regarding the diagnostic performance of the dispersion slope for assessing the inflammation. We should congratulate Dr. Sugimoto and colleagues for their very nice work. The first one is an experimental work in rat livers with various degrees of necroinflammation and fibrosis. And as you can see here, fibrosis grade was significantly related to shear wave elastography. We know that, it has been proved already, while necrosis grade was significantly related to the dispersion slope. So very interestingly, but an experimental work. Recently, they have also published a prospective study in more than 100 patients with suspected non-alcoholic steatohepatitis, and their results are extremely important. So they evaluate the dispersion slope, the attenuation coefficient, and the liver stiffness. And you can see here on the graph below that there is a very good correlation between the dispersion slope and the lobular inflammation grade. Higher the slope, higher the lobular inflammation grade. And on the right, these are the area under the curve of the dispersion slope according to the different grades, more than 1, more than 2, or more than 3. And in all situations, the diagnostic performance has been very high. This is the first, I would say, very important paper in patients. This has to be confirmed, but I'm quite optimistic that dispersion slope can become an important biomarker for assessing liver inflammation. I would like just to show you some examples. This is a patient who had an increase of GGT, a moderately increase in AST. There was no abnormality on MRCP, so the patient had complete evaluation plus a liver biopsy. And you can see here below that we can have a graph showing the simultaneous value of shear wave elastography, of shear wave dispersion slope, as well as attenuation coefficient. And actually, more of the values were in the green or orange area, and indeed the patient had healthy liver. If we look now at another case, okay, and then this is the results of the biopsy. No steatosis, no fibrosis, no attenuation. Now the next patient here, you can see that it is different, and we have actually a high attenuation value, moderate increase in shear wave elastography. And again, if we look at biopsy results, the patient had moderate steatosis, slight degree of fibrosis, and some inflammation. Last patient where I want to share with you, you can see here that the shear wave elastography is increased about 8 kilopascal, that the dispersion is very increased, it is in the yellow box, and again there is also an increase in the attenuation value, and the biopsy revealed that there was steatosis, F3, as well as inflammation, liver inflammation graded 3. So here we have example that we can really move forward and non-invasively assess the degree of fibrosis, steatosis, and attenuation. Why is it so important? Because we have more and more patients with NAFLD, and this comes from a very important article showing the global prevalence of NAFLD among the type 2 diabetes patient, and it's more than 50%. In our institution, as well as in another one, we have started to try to develop a virtual biopsy, especially in those patient type 2 diabetes, that will prevent all the different steps between endocrinologist, hepatologist, liver biopsy, and try to have a combination of biomarkers enabling to calculate the virtual liver biopsy. And we should get the results in a year. With that, I would like to conclude. First of all, liver stiffness using shear wave elastography is easy to use and correlates well with transient elastography. This is a very important biomarker for chronic liver disease, and I strongly encourage people to use it routinely. Second, attenuation imaging is easy to use, correlate well with quantification of fat, but we will know more about that with the second lecture. Dispersion imaging theoretically reflects liver inflammation, and we have very promising results, but still to be confirmed. These new tools altogether certainly complete the armamentarium of ultrasound, making a comprehensive multimodality imaging technique. And with that, I would like to thank you very much.
Thank you very much, Professor Villegrain, for this very clear presentation. Our second speaker for today is Dr. Giovanna Ferraioli from University of Pavia. She is ultrasound leader and researcher at ERCCS Policlinico San Matteo Medical School, University of Pavia. She is co-director of the FSUM Ultrasound Learning Center and member of FSUM expert team for the guidelines on liver elastography, and also member of WFUM expert panel for the update to the guidelines on liver elastography. She has published several scientific articles in international journals, including Gastroenterology, Hepatology, Journal of Hepatology, European Radiology, or Digestive and Liver Disease. And today, she will share her experience in non-invasive liver steatosis quantification. Dr. Ferraioli.
Thank you. Thank you for this kind introduction, Nadine. Non-alcoholic fatty liver disease is currently the most common chronic liver disease worldwide. And why is so important to quantify the content of fat in the liver? There are at least two main reasons. The diagnostic and quantification of fat in the liver can predict the development of diabetes and cardiovascular events. But also, it has been shown that significant steatosis is associated with the progression of fibrosis in patients with non-alcoholic fatty liver disease. So the quantitative assessment of the content of fat in the liver is of great interest. Liver biopsy is the reference standard for the assessment of diffuse liver disease and also for the assessment of the fat content in the liver. However, liver biopsy cannot be applied to the vast majority of patients just for screening of liver steatosis. In 95% of cases, NAFLD is a benign disease with only steatosis. On the other hand, when we want to look at the accuracy of the new algorithms that are able to quantify the content of fat in the liver by ultrasound, we have a bias using liver biopsy because the patients that will undergo liver biopsy are likely the patients with a more severe disease or with underlying conditions. On the other hand, liver steatosis, unlike liver fibrosis, is a dynamic process that may improve with appropriate lifestyle changes within a few weeks. Therefore, the possibility to non-invasively detect the fat in the liver is of great interest. And proton density fat fraction obtained with magnetic resonance is a very useful tool for the assessment and the quantitative assessment of fat in the entire liver. And it has become a reliable alternative to the histological assessment of liver steatosis. On the other hand, we have to take into account that liver biopsy gives an assessment of fat in the liver in a categorical scale, whereas PDFF and tool available on the ultrasound, on an ultrasound system quantifying the attenuation, they give a numerical value. The first tool available for the quantification of fat in the liver is the controlled attenuation parameter. Available since 2010, the measurement of the attenuation is in decibel per meter. We use the M probe or the XL probe, and the ROI is in a fixed one with the M and the XL probe. A dedicated device is needed. We do not have any image of the liver. There is a large overlap between consecutive grades of liver steatosis, and studies have shown that the controlled attenuation parameter is outperformed by PDFF for the grading of liver steatosis. On the Canon system, there's the attenuation coefficient. The trade name is ATI, and the ATI quantifies the attenuation of the ultrasound beam like a controlled attenuation parameter, but in a large area, and the attenuation is color-coded. The radio frequency data are used, therefore the measurement is not affected by the post-processing of the data or by the settings that we use on the ultrasound systems. And the algorithm is able to filter out structures like vessels or strong artifacts and reverberation artifacts. The quantitative measurement is obtained in decibel per centimeter per megahertz. The attenuation coefficient that we obtain is the median value of 5 consecutive measurements. And the reliability of each measurement is displayed on the screen as an R2 value, and you can see here, and is the best quality of the attenuation coefficient is when the R2 value is 0.90 or higher. Also, having a color-coded attenuation, we may look also at artifacts and not include them in the measurement box. This is very different from CAP and helps a lot in choosing the area where to perform the measurement. And the artifacts may appear as a thick orange line in the near field or dark blue areas, usually in the far field due to the high noise, or sometimes we observe also dark blue areas posterior to blood vessels. As you can see here, on your left side, you see the artifacts due to the reverberation. They are not included in the measurement box. And here in the far field, blue dark areas posterior to vessels or in the far field due to the high noise. There are several studies. ATI is available since very few time, but there are already several published studies in the literature, and studies that have looked at the performance of the ATI. As of today, we have 5 studies that have used histology as the reference standard, and 4 studies that have used the PDFF as the reference standard. And in all these studies, the accuracy in detecting and grading levosteatosis was pretty high. In our study, we have assessed also the reproducibility of the measurements to operators. The reproducibility was assessed in 30 subjects. And as you can see here, the overall agreement was higher than 0.90, 94%, but also the intra-observer and the inter-observer agreement, they were both higher than 0.90. So it's a reproducible, highly reproducible technique. The accuracy of ATI was assessed by our group in consecutive subjects potentially at risk of steatosis and also healthy volunteers. And each subject underwent on the same day measurements with the ATI and CAP, and the PDFF was performed within a week. And of course, the radiologist performing the PDFF was unaware of the results of ATI and CAP. And these are the value that we use for the PFF for the detection and grading of liver steatosis. As for the baseline characteristics of the patient, you can see here that patients without steatosis were younger and they had a lower BMI. And both for the ATI and for the CAP, an increase of value, increasing the amount of fat in the liver was observed. What is really interesting, as you can see, the IQR, there was not an overlap of IQR for ATI, for S0, S1, and S2. Instead, for CAP, there's an overlap for all the 4 grades of liver steatosis. And when we assess the concordance with the PDFF, the concordance of ATI was significantly higher with PDFF, was significantly higher than the concordance of the controlled attenuation parameter. And these are the ROC curves for S higher than 0 for detecting steatosis and for detecting significant steatosis. The ATI was more accurate than the CAP, and this accuracy was significant for the assessment of significant steatosis. These are the cutoffs obtained for ATI and for CAP for patients with for the detection of liver steatosis and for significant steatosis. And as you can see, sensitivity, specificity, positive and negative predictive values were higher for ATI respect to CAP. What were the cutoffs? For the detection of steatosis, 0.63 decibel per centimeter per megahertz, and for significant steatosis, 0.72. But we obtained also 2 cutoffs, one to rule out steatosis, 0.59, and the other one to rule in steatosis at 0.70, with a specificity of almost 100%. And interestingly, in a study performed using liver biopsy as the reference standard, the cutoff for detecting steatosis was similar to the one we found in our study. And in this study, fibrosis and necroinflammatory activity were not associated with ATI. So this fibrosis is not affecting ATI results. In this study, we used the AT package tuned on a US frequency of 4 megahertz, what is named the ATI gen. But to allow a better penetration in difficult case, ATI is also available at an ultrasound frequency of 3 megahertz, the ATI pen. It's well known that the attenuation is directly related to the transducer frequency. Higher the frequency, higher the attenuation. Therefore, a change in ultrasound frequency used to obtain the attenuation coefficient may also give a different result in the same subject. We have performed another study in 72 subjects using the ATI gen, the ATI pen, CAP, and PDFF as the reference standard. And you can see here that the correlation for both ATI-pen and the ATI gen were higher than the correlation of CAP with the PDFF. And as for the cutoff, as expected for ATI pen, the cutoff is higher than for ATI gen. And sensitivity and specificity were pretty high and higher than controlled attenuation parameter. And using the regression analysis, we found also a regression equation to convert the ATI gen in ATI pen or vice versa. And this equation could be very useful to have a similar value using a different setup. So in conclusion, ATI is a reliable tool for the detection of liver steatosis and is highly accurate in detecting and grading liver steatosis. And ATI performed better than CAP, and this improvement was statistically significant for significant steatosis. We have to take into account the frequency dependence when we calculate the attenuation coefficient, because it's not in comparing results obtained with different settings, we have to take into account this limitation that is important to use different cutoffs with a different setting. Thank you very much for the attention.
Thank you very much, Dr. Ferraioli, for this very clear lecture, I would say. During your lectures, your respective lectures, I have collected some questions from the audience. So I will try to combine them by category: fibrosis, steatosis, and inflammation dispersion. So regarding the fibrosis and fibrosis assessment, so one question: is there a universal threshold value on shear wave, whatever the manufacturer used?
This is definitely a very good question. As I said before, there are many factors that may affect the result of shear wave elastography. The manufacturer itself, the beamformer, the probe. And now many manufacturers have launched their 2D shear wave elastography. It is unfortunate that not all of them have been clearly validated. I think that we need large series, multicentric series with the method of reference, either the liver biopsy or I would say the classical reference method, which has been the transient elastography. So I personally consider that only 3 manufacturers have really validated the result of shear wave elastography. So this is first, it is very important to get this clinical validation. And phantom validation is very different because you are not live, you are not in patients. The second thing, which is very important, do we get reliable cutoff? And here I can say yes, more or less yes. We know the classical cutoff produced by transient elastography, they have been validated with the other techniques. I would say from a clinical perspective in adult patients, not necessarily in a pediatric population, but the most important is not for us to differentiate F0 from F1, but F0, F1 versus F2, F3, F4. So here we have a lot of data, and the data show that the classical cutoff is something around 7.1, 7.2 for transient elastography, 7.1 for shear wave elastography. Here, I think we can really be sure of that. And then we have other cutoffs, but I think that the most discriminant for patient management is certainly F0, F1 versus F2 and more.
Thank you. Second question, can we correlate US results with liver MRI elastography?
Okay, regarding liver stiffness, this is a very good question. Actually, one thing has to be known is the value you get with ultrasound is completely different from that with MR. And we have a healthy liver with value obtained with ultrasound-based or transient elastography 5, 5.5, 6 kilopascal. This is a healthy liver with no fibrosis, whereas a healthy liver at MR elastography would be something around 2, okay? So we have to make the comparison and to accord the different scales. Having said that, yes, we can say that the techniques correlate pretty well. There has been a recent paper comparing transient elastography, ultrasound-based elastography, and MR elastography, and they have shown a very good correlation, spatially, and a high diagnostic performance in high stages of fibrosis, F3, F4, and indeed, any technique has got lower diagnostic performance looking at lower values. But overall, the correlation works pretty well.
Thank you. And now a question making the bridge with the steatosis. How influence liver stiffness with liver steatosis? And the other way around.
Is the question for me or for Dr. Ferrioli?
For
I
think you're both very experienced to answer this question.
I will answer first. Studies that have been performed using liver biopsy as the reference standard up to now, they didn't find any correlation or any influence of fibrosis on the number obtained using the ATI. So seems it's not a confounding factor, liver fibrosis. Using the controlled attenuation parameter, there are conflicting results in the literature, because some studies, there is one study that found an increase of stiffness at the same stage of liver fibrosis in case of severe steatosis. However, in this study in obese patients, the M probe of the FibroScan device was used, so maybe there was an overestimation of liver stiffness. The literature so far didn't, for the ATI, found any influence of fibrosis on the value that we obtain with ATI software.
Right. I completely agree with you. I think we can say that presence of liver steatosis marginally influence liver stiffness, and only if liver steatosis is really severe. But on a general basis, no. You agree with that?
Yeah, completely.
Let's continue. First of all, thank you. Let's continue with steatosis. What is the learning curve of ATI technique? How many times did you need before starting the study to be comfortable and to be used with the technique?
There is no study yet about the learning curve, but it's very simple. For people that are already expert in performing the assessment of liver stiffness. The intercostal space is used the same as for liver stiffness, and the color map helps in identifying area where the measurement should not be performed. The software completely eliminates a pierce blank area of artifacts. However, we have some of artifacts in the near field or in the far field, but they are very well shown with the color. And the learning curve is a few days. For colleagues already expert in liver shear with elastography.
So would you see any pitfalls in the interpretation of ATI?
No. No, if the artifacts are not included in the ROI when we perform the measurement. Of course, the quality of the B-MODI image is always of importance, but for expert in ultrasound and in assessment of liver stiffness, there's no problem.
Thank you. It seems there are now several other attenuation techniques available on the market. Can we use ATI cutoff, or do we use specific cutoff also for every system?
It's too early to answer this question. It's really too early. There are several. The value are all in decibel per centimeter per megahertz. And looking at the published studies, the cutoff are almost similar. But it's too early because the attenuation, it depends on the frequency that it is used. So it's important to know what is the frequency used to correlate with the cutoff. On the Canon system, we have two settings, the ATI gen, the ATI pen. The ATI pen is very useful in obese patients. We usually start with the ATI gen, that is in the majority of the patient, it works very well. When the color map is not filled with the color and we have a lot of blank areas, we switch to the ATI pen. The cutoff is higher. So without knowing the frequency that is used by other vendors, we cannot compare the value.
Thank you, Dr. Ferrari. Now, the next part is for about dispersion. So, almost the same question. Is shear wave dispersion also affected by liver fibrosis?
That's a very good question, and the answer is yes. There is clearly a relationship between the dispersion slope and the liver fibrosis. It's not as well as correlated as with the shear wave elastography, but this plays a role, and that's why future work is really needed to try to separate the influence of liver fibrosis and from liver inflammation for dispersion slope.
And what would be the other factors that could influence this dispersion?
Well, we are with the dispersion slope, we are a bit entering in a new world. So I think that things are not as well as established as with liver stiffness and fat quantification. So I would be very cautious about that. I think we are still in the learning curve. We might imagine that other, I don't know, but maybe congestion, maybe other factors could play a role as well. I think there are still open questions about that.
Okay, and could we compare dispersion with any other diagnostic tool at the moment, or?
Well, we use as a reference standard the liver biopsy, but liver biopsy itself is a bit confusing because what is exactly liver inflammation? First of all, I'm not a pathologist, but working closely with pathologists, this is what I have learned. Liver inflammation that you may see in a viral hepatitis is completely different from liver inflammation in NAFLD patients. And actually, it's much more important in active hepatitis. I mean, active hepatitis B. Okay. Then within liver inflammation, we talk about different things. We can speak about ballooning. We can speak about lobular inflammation. So there are several things that have been put together. And we don't know today exactly the relationship between each individual pathologic item. So this is certainly the problem, and we are not speaking exactly the same language according to the different patients. We want to focus as anyone on the NAFLD because assessing inflammation is important. Although I want also to mention that today, the most important prognostic factor in NAFLD patient is not steatosis. It is probably not inflammation, but it is fibrosis. And here we know that we have a very reliable biomarker. So that's really a message I want to give you tonight. Fibrosis is really important in many conditions. The classical hepatitis, related fibrosis or cirrhosis, but also as a major prognostic factor in NAFL patients. With the dispersion, the idea and the hypothesis is to get more closely to really what happens within the hepatocyte. But we have to confirm the very promising result, and we have to correlate with any individual, I would say, pathologic feature.
Thank you. And because I've seen several questions about that, can we correlate dispersion with AST or LAT?
Yeah, theoretically, yes, it could be interesting because it reflects certainly the activity. I've not seen up to now, I think, articles that have compared. I don't know if Giovanna Ferraioli has seen such papers. This could be certainly interesting because these are clinically used biomarkers to assess the activity.
No, there are no published paper so far. It's a very interesting field and theoretically is exciting, but we don't know yet the real value, and studies are strongly needed. So I would encourage everyone participating in this webinar to think about this and start the studies.
Yes, because if there are some questions, and it seems it's this what you have said means dispersion to define cutoff values for dispersion. We have to correlate them with specific disease to identify
yes.
cutoff. We cannot get a universal cutoff like fibrosis.
This is exactly what I want to mean. That there is inflammation, and inflammation is very specific of one disease and another one. At the beginning, when we have started working on shear wave elastography, we have also combined different types of people, chronic hepatitis and NAFL. But we know also that the fibrosis is not the same, because we include the perisinusoidal fibrosis in NAFL, and the score used to grade the fibrosis in NAFL patient is different from that used in hepatitis patients. So we have to be very cautious, and after exploring, because we are still, I think, in the exploring step for dispersion, now we should focus really on patient population. The very important one to date is the NAFL population, because they are antiviral that are very active with hepatitis C and also with hepatitis B to control inflammation. But now the key question is certainly to learn more about the liver inflammation in NAFL patients.
Okay, thank you. And as with dispersion, we are reaching a very promising topic. Let's come back to routine. So, would you recommend these techniques as a routine technique?
Indeed. I think the first thing we do when we have, on the first day the residents start in the department, is how to do shear wave elastography. And we ask for routine examination, shear wave, liver stiffness, ATI in patients who have a suspicion of chronic liver disease. I think it is very, very important. Shear wave elastography is really a beautiful biomarker, and no doubt that ATI will become as well, and we can, hope or hypothesize that it will be the same with the dispersion slope, but we are not there.
I completely agree.
Thank you. And probably the last question, could you give us an idea about the time needed to perform a complete examination about fibrosis, steatosis assessment, and inflammation assessment with the dispersion? how much time do you,
okay,
you quantify?
So with the Aplio series, it is interesting because it combines the measurement of shear wave elastography and shear wave dispersion. So we have, I would say, 2 in 1. Then indeed, we have to perform several measures, okay? 3, 5, there are still people that talk about that. Anyhow, I mean, if you are a bit trained, and it's not a long training, but we have to be very rigorous, patient position, intercostal approach, and so on and so on. I think it goes fast. I mean, on a routine basis, in a patient, for the shear wave elastography, shear wave dispersion plus ATI measurement, you don't add more than 5 minutes, and it's often less than that.
Yes,
do you agree
for,
with that?
yeah, agree. And for ATI is quite simple. You need seconds. Once you have the intercostal approach for the assessment of the stiffness, the 5 measurement for the ATI, they can be done in very few seconds, one image after another.
Thank you again. And yeah, I think I probably can speak in the name of all the audience. Dr. Ferraioli, Professor Villegrain, I would like to thank you again for these very, very nice lectures and very clear explanations. And I wish you all a very nice evening. Thank you all.
You too. Bye-bye.
Bye.
Bye-bye.